All right, continuing with our review of the NBME style questions. Here's the next question. A 13-year-old girl, a pediatric child neurology question. So that will be interesting. 13-year-old girl presents to the hospital after more than 24 hours of decreased mental status, left-sided hemiparesis involving the left upper and lower extremity and left side of the face. Wow. So a 13-year-old with a hemiparesis presenting more than 24 hours with decreased mental status. So that's unusual. You would expect someone like that would to present immediately, right? You think of stroke, and everybody wants to just present right away for acute stroke-like presentation. But usually, mental status is not impaired in stroke, so that is a somewhat of a concern here. And then more than 24 hour of presentation is also concerning. At presentation, she's noted to have a GCS score of 6, temperature of 101.8, so she's definitely febrile, with a low Glasgow Coma score, scale score, GCS, and a pulse of 105. GCS 6 is very low score. Normally anything below 15 is impairment, like 10, 12, 11, but 6 is very low. 3 is coma, so she's barely above coma. Her pulse is 105, which could be tachycardia related to her age with temperature. The mother states that the patient had a normal seizure episode for her, which involves a staring spell followed by headaches and hemiparesis with pain in the extremities lasting 12 hours. So that might be a reason why she's presenting more than 24 hours later, because she used to have seizures, and her normal spell is that she has a staring spell, which is followed by headaches, and then she has a hemiparesis with pain that lasts 12 hours. So they waited. Well, she will get better after 12 hours, like her usual spell. But this time, however, the patient has prolonged decreased mentation and hemiparesis, so it's lasting more than 12 hours. So it's an atypical episode. The patient's past medical history is notable for genetic disorder associated with mitochondrial complex 1 deficiency, seizures, and headaches. Physical exam showed leftward eye deviation, equal and sluggishly reactive pupils, left-sided hypertonia with 2+ reflexes bilaterally. The patient does not move the left side upper and lower extremity spontaneously and moves anti-gravity to noxious stimuli, but has purposeful movements on the right. So clearly a left hemiparesis. There's a leftward eye deviation, which means there could be a right frontal lesion pushing the lesion away, eyes away from the lesion, equal and sluggish reactive pupils, left side hypotonia, which is related to the hemiparesis, and a 2+ reflexes, meaning there is no loss of reflexes. Patient has also a left side facial droop with flattening of the nasolabial fold, all consistent with the history so far, and what is the most appropriate next step in management of this patient. So patient has a mitochondrial disorder. She used to have spells. She has a prolonged postictal with hemiparesis and pain and headache, but this is now lasting much longer than 12 hours. And the question will be, has the patient had a stroke, which has caused a permanent loss of damage more than usual, or she may have because of a mitochondrial disorder. Normally, these patients get these cortical edemas, which presents with stroke, but often they resolve, and sometimes they resolve after days or sometimes even weeks. But you need to see what's going on in the brain. The question will be, is she in status, so continuing seizures, and that's why she's not coming out of it, or is she had a stroke and needs an MRI? So imaging, MRI of the brain, and an EEG would be my top priorities and concern. Other options here listed are lumbar puncture. That could be reasonable, especially given her fever. You want to rule out a meningitis encephalitis scenario, which could have resulted in her seizure or multiple seizures or atypical postictal. Amitriptyline was not going to help her here. Sumatriptan is not an issue. This is not a hemiparesis migraine. It's contraindicated to use sumatriptan or any triptan. And then reassurance and observation, I think, is not right, because this did more than 24 hours, is definitely atypical than her usual baseline spell. She is febrile, she's tachycardic, so this needs to be evaluated for sure. And of these options, EEG seems to be most reasonable to me. So let's look at next option. And EEG is the answer. Between EEG and MRI, I would wonder. I would probably, practically speaking, do MRI first, just because once you're hooking up with EEG take a while, and EEG leads often are incompatible with MRI. And if she has a history of mitochondrial disease, she may have cortical strokes with edema, which may be causing her status. So even if she is in a status right now, status epilepticus, that may be because of some cortical strokes or edema. Strokes, these are lected strokes, so these are not typical ischemic strokes. These are different unusual strokes, which is more like a cortical edema or swelling because of hyperlactate deposition. And they are often fully reversible. And patients have very excellent recovery from these kind of mitochondrial lactate related strokes. All right, let's stop here and we'll review another question in a separate video.